Welcome back to our channel. We will simplify parenteral nutrition, an essential topic in critical care and a favorite in MBBS, NEET PG, and USMLE exams. We will learn how to calculate the three major nutrients dextrose, amino acids, and lipids, understand the five key electrolytes, recognize common complications, and apply practical management strategies. By the end of this lecture, you will be able to confidently prescribe and monitor the TPN, total parenteral nutrition, in critically ill patients. Let's begin with a real ICU scenario. Meet Mr. Suresh Mehta, a 55-year-old man who is 5 days after emergency small bowel surgery. His gut is temporarily unusable, so he was started on TPN through a central venous catheter. He was already severely malnourished before the surgery, with significant weight loss, a low BMI, and type 2 diabetes. TPN was started early at the full target calorie requirement. Now he develops progressive muscle weakness and difficulty in breathing. His laboratory tests reveal severe hypophosphatemia, hypokalemia, hypomagnesemia, and hyperglycemia. Pause for a moment and think what serious complication has occurred? How could it have been prevented? We will uncover the answer in next slide. The correct answer is option B. This patient is experiencing refeeding syndrome, a potentially life threatening complication caused by rapid nutritional replacement in a severely malnourished patient. The immediate management is not to stop TPN completely because that can lead to rebound hypoglycemia and further nutritional compromise. Instead, reduce the TPN to about 10 kilocalories per kilogram per day. Aggressively replace phosphate along with the potassium and magnesium as needed, and administer IV thiamine before continuing carbohydrate feeding. Avoid increasing the dextrose concentration as it triggers a larger insulin surge, driving the electrolytes into the cells and worsening hypophosphatemia, hypokalemia, and hypomagnesemia. Example: in any malnourished patient starting TPN, always think of refeeding syndrome. The key management steps are slow feeding, thiamine supplementation, and aggressive electrolyte replacement before advancing the nutritional support. The fatal errors and the safe approach. One of the biggest challenges in parenteral nutrition is avoiding the preventable mistakes that can lead to serious complications. The first fatal error is starting full calorie TPN immediately in a severely malnourished patient. This dramatically increases the risk of refeeding syndrome. Instead, begin at 10 kilocalories per kilogram per day and gradually increase the calories over 5 to 7 days while closely monitoring the electrolytes. The second mistake is exceeding the maximum dextrose infusion rate, which should generally not exceed 5 milligrams per kilogram per minute. Excess glucose promotes hyperglycemia, fatty liver, and increased carbon dioxide production. Third, high osmolarity TPN should never be infused through a peripheral vein. Solutions with an osmolarity greater than 900 milliosmoles per liter requires a central venous catheter to prevent thrombophlebitis and vein injury. Finally, always monitor the serum triglyceride levels during the lipid therapy. If triglycerides rise above 400 milligrams per deciliter, temporarily hold the lipid infusion and reassess the patient. The 5-step PN initiation algorithm. Whenever you plan to start the parenteral nutrition, follow the 5 simple algorithm steps to ensure safe and effective management. Step 1 is to confirm the indication. Parenteral nutrition should always be used when the GI tract is non functional or cannot be used for more than 5 to 7 days. Remember, if the gut works, use the gut. Step 2 is to calculate the patient's nutritional requirements. Most adults require 25 to 30 kilocalories per kilogram per day, with 1 to 2 grams of protein per kilogram. As a general guide, about 60% of non protein calories come from dextrose and 40% from the lipids. Step 3 is to screen for refeeding syndrome risk. Look for the patients with a BMI below 18.5, significant recent weight loss, prolonged starvation, or chronic malnutrition. These patients require extra caution. Step 4 is one of the most important exam points. Administer IV thiamine before starting the carbohydrates. Give 200 to 300 milligrams of the IV thiamine to reduce the risk of Wernicke's encephalopathy and other complications of the refeeding syndrome. Finally, step 5 is to advance the nutrition gradually while monitoring closely. Increase calorie delivery by about 30 to 33% every 1 to 2 days and monitor electrolytes, blood glucose, fluid balance and clinical status daily. So, this is your example. Before starting the parental nutrition, always remember the sequence. Assess the indication, calculate the requirements, screen for refeeding risk, give thiamine first, and then start slow and advance slowly while monitoring the patient closely. Macronutrient master calculation. Now let's calculate a complete parental nutrition prescription step by step using our patient Mr. Suresh, whose target weight is 58 kilograms. We begin by calculating the total delivery daily energy requirement. At 25 kilocalories per kilogram, the total comes to 1450 kilocalories per day. Step 1 is calculating the protein requirement. At 1.5 grams per kilogram, the patient needs 87 grams of protein daily, providing the 348 kilocalories. Next, subtract the protein calories from the total calories. So, this leaves 1102 non protein calories, which are divided between dextrose and lipids. For dextrose, allocate 60% of the non-protein calories. This equals approximately 194 grams of dextrose per day. Always verify the glucose infusion rate. In this case, it is 2.3 milligrams per kilogram per minute, which is safely below the recommended maximum of 5 milligrams per kilogram per minute. The remaining 40% of non protein calories are supplied as lipids, which equals approximately 220 milliliters of 20% lipid emulsion per day. This provides a lipid dose of 0.76 grams per kilogram per day, well within the safe limit of less than 2.5 grams per kilogram per day. Electrolyte management is one of the most important aspects of safe parenteral nutritional therapy. For most adult patients, the daily maintenance requirements include 1 to 2 milliequivalents per kilogram of sodium and potassium, 20 to 40 millimoles of phosphate, 8 to 20 milliequivalents of magnesium, and 10 to 15 milliequivalents of calcium. These values should always be individualized based on the patient's clinical condition and the laboratory results. In acute or chronic kidney disease, the kidneys cannot excrete electrolytes effectively. Therefore, potassium phosphate and magnesium doses should usually be reduced to avoid dangerous accumulation. In liver failure, patients are more prone to hyponatremia, so sodium replacement should be carefully adjusted according to the serum sodium levels and fluid status. Patients with refeeding syndrome require the opposite approach. They often develop profound hypophosphatemia, hypokalemia, and hypomagnesemia, requiring aggressive IV replacement while nutritional support is induced slowly. Patients with GI fistulas or high nasogastric losses lose large amounts of sodium and potassium. These ongoing losses must be replaced daily to maintain the electrolyte balance. Finally, always remember the osmolality rule. If the TPN osmolality exceeds 900 milliosmoles per liter, the solution must be administered through a central venous catheter. Peripheral veins cannot safely tolerate highly concentrated solutions. To understand why refeeding syndrome is so dangerous, let's walk through its mechanism step by step. Phase 1 is starvation. During prolonged fasting or severe malnutrition, insulin levels fall, and the body switches from using carbohydrates to burning fat and protein for energy. Although the body's total stores of phosphate, potassium, and magnesium become depleted, blood levels may still appear normal, making the deficiency easy to miss. Phase 2 begins with carbohydrates such as dextrose and TPN and suddenly reintroduced. This causes a rapid surge in the insulin secretion. Phase 3 insulin drives glucose into the cells for energy production. At the same time, phosphate, potassium, and magnesium are rapidly pulled from the bloodstream into the cells to support the ATP synthesis and other metabolic processes. This leads to phase 4, the systemic crash. Serum phosphate levels can fall dramatically, often below zero point 0.5 millimoles per liter, resulting in severe ATP depletion. Patients may develop muscle weakness, respiratory failure, life threatening cardiac arrhythmias, heart failure, seizures, and even sudden death if the condition is not recognized promptly. Although parenteral nutrition is life saving, it is associated with several important complications that every clinician should recognize. The first and the most common complication is hyperglycemia, usually defined as a blood glucose level above 180 milligrams per deciliter. Blood sugar should be managed with a separate IV insulin infusion rather than adding insulin directly into the TPN bag. The second complication is the refeeding syndrome, characterized by severe hypophosphatemia, hypokalemia, and hypomagnesemia. If not treated promptly, it can lead to fatal cardiac arrhythmias, respiratory failure, and death. The third complication is catheter related bloodstream infections or CRBSI. Common organisms include the coagulase negative Staphylococcus aureus, and Candida species. Strict aseptic technique and proper central line care are essential to prevent the infection. The fourth complication is TPN associated liver failure, also known as TALD. Excessive dextrose administration, hepatic fat accumulation, and prolonged absence of enteral feeding can lead to cholestasis and liver function. The fifth complication is fat overload syndrome or severe hypertriglyceridemia. Severe triglycerides should be monitored regularly, and lipid emulsions should be withheld if triglyceride levels exceed 400 milligrams per deciliter. Finally, hypercapnia can occur when excessive carbohydrate intake increases carbon dioxide production. This is especially important in mechanically ventilated patients where excess CO2 can make weaning from the ventilator more difficult. Certain clinical findings require immediate modification of the parenteral nutrition. If serum phosphate falls below zero point 0.5 millimoles per liter, suspect severe refeeding syndrome. Stop advancing the calories, reduce the TPN rate by 50%, begin aggressive IV phosphate replacement, and monitor the electrolytes every 6 hours. If blood glucose remains above 180 milligrams per deciliter despite the insulin, reduce the dextrose infusion and initiate an IV insulin protocol to maintain a target glucose of 140 to 180 milligrams per deciliter in critically ill patients. In patients with fever, rigors, and a positive central line culture, suspect a catheter related bloodstream infection. Remove or exchange the central venous catheter when indicated, especially in Staphylococcus aureus or Candida infections, and start appropriate antimicrobial therapy. Finally, if the triglyceride levels exceed 400 milligrams per deciliter, stop the lipid emulsion immediately and restart only after triglycerides fall below 200 milligrams per deciliter. Remember, early recognition of these red flags can prevent life threatening complications and improve the patient outcomes. Successful parenteral nutrition doesn't end after starting the infusion. It requires structured monitoring. Before initiating the TPN, check sodium, potassium, phosphate, magnesium, and calcium to assess the refeeding risk. Also, obtain the baseline liver function test, triglycerides, and administer IV thiamine when indicated. During the daily monitoring, check blood glucose every 4 to 6 hours until stable, aiming for 140 to 180 milligram per deciliter. Monitor the electrolytes, phosphate, and magnesium, especially during the first week, and assess the fluid balance and daily weight. On a weekly basis, evaluate liver function tests to detect the TPN associated liver disease, monitor the triglycerides, and measure prealbumin as an early indicator of nutritional response. Let's apply this concept with a clinical scenario. A ventilated ICU patient receiving the TPN has persistent hypercapnia with a PaCO2 of 58 milliliters of mercury, making ventilator weaning difficult. The correct management is to reduce the dextrose content of TPN and shift the more calories to the lipids. Why? Because dextrose has a respiratory quotient of 1.0, producing more carbon dioxide during the metabolism, while the lipids have a respiratory quotient of only zero point 0.7, generating less carbon dioxide. Let's solve another high yield clinical case. A patient on TPN is receiving 120 grams of amino acids per day and 24-hour urinary urea nitrogen or UUN is 18 grams. To calculate the nitrogen balance, use the formula nitrogen in minus nitrogen out. Nitrogen intake equals 120 divided by 6.25, which is 19.2 grams. Nitrogen output equals 18 grams of UUN plus 4 grams of insensible losses, giving a total of 22 grams. Therefore, nitrogen balance is 19.2 minus 22, which equals negative 2.8 grams per day. This indicates a negative nitrogen balance, meaning the patient remains in a catabolic state. The goal is a positive nitrogen balance of plus 2 or plus 5 grams per day. A negative balance suggests the need to increase the protein intake or reducing the ongoing catabolic stress to promote the recovery and healing. Let's conclude with Indian perspective on parenteral nutrition. India has a high burden of malnutrition, making many patients vulnerable to refeeding syndrome. Therefore, careful nutritional assessment is essential before initiating the TPN. Because thiamine deficiency is common, especially in patients with poor nutritional status. IV thiamine should be administered before starting the parenteral nutrition whenever refeeding risk is suspected. In India, commonly available 3-in-1 premixed TPN formulations include Cabiven and Olimel, while SMO lipid is often preferred to reduce the risk of the TPN associated liver complications. Finally, strict aseptic parenteral preparation is crucial. When long term TPN is required, PICC lines are generally preferred over repeated central venous catheter insertions to reduce the infection risk. Let's summarize the key concepts of the TPN. Always remember the maximum safe limits. Keep dextrose below 5 milligrams per kilogram per minute, lipids below 2.5 grams per kilogram per day, and maintain triglycerides below 400 milligrams per deciliter. For calculations, remember these values. Dextrose provides 3.4 kilocalories per gram, protein provides 4 kilocalories per gram, and 20% lipid emulsions provide 2 kilocalories per milliliter. Finally, follow the three golden rules of safe TPN. Start low in patients at risk of refeeding syndrome. Administer thiamine before carbohydrates and use a central venous catheter when the solution osmolarity exceeds 900 milliosmoles per liter. Thank you for watching this presentation on parenteral nutrition in critical care. I hope this session has helped you understand the principles of the TPN, including the nutrient calculations, electrolyte management, refeeding syndrome, common complications, and safe monitoring strategies. If you found this video helpful, please like, share, and subscribe to support more evidence based medical education. Feel free to leave your questions or suggestions in the comments. They'll shape our future content. Thank you, keep learning, and I'll see you in the next lecture. Stay safe and keep saving lives.